Saliva doesn't have steroids. I mean, it may have steroids, but not as much as urine. I'm not a promoter of urine, but
No, but why he's asking is, lot of our Jain saints. No. Even our Jain saints, anything goes wrong with the eyes, they put the saliva. I mean, we scold them.
it
Actually, I
could
scold
be.
them, but they use saliva.
It could be. It could be. I mean, people use honey. In honey has a lot of growth factors.
Have you seen about saliva? Anything?
See,
My daddies used to use that
lot
for
of
skin
things.
allergies and all that.
see, saliva is antibacterial because there's so much of microbiomes there in the thing. It could have some impact on it. Kelage. This is something which is very important. Which these ion channels are there in your corneal epithelial cells. You have sodium channels, potassium channels, and calcium channels. Abha is going to smile about it because the way I taught them is, for people who worked with me, sodium channel is like Girija for staff. She just, and potassium is like how people, and C stands for Cynthia, so she's an amplifier. So I keep telling them that you remember them by the, or you can call it Sri Harsha, accelerator. So I'm just, because it's so important, what does your paracaid do? It works on the sodium channel. See, these things drive the entire complex situation of your cataract, or what happens is your betadine alters the calcium channels completely. So when you have people who have already altered, patients complain of complete chronic pain, it's your calcium channel which works. Funny, next slide. And what really changes them is these three, the TRP1, 8 and A1. This is very important for everybody because the V1 is like chili. So you put chili, that's why it's called capsicum. And TRPM8, it is menthol because they have tested the receptors on chili, menthol and irritants. So that's why you can see it's a heat receptor. So what we need to do in what Alcon has come out is, it increases the TRP8, that calm, cool cartoon which you have. And what really causes a very important aspect of post-cataract change is TRP1. And what can you do to reduce it? You have both resveratrol, curcumin, omega-3 and trehalose can reduce the TRP1. But what is very interesting is the omega-3 drops and the trehalose not only reduces V1 but increases M8. So if you get a calm feeling, what Alcon has done is, when you put TRPM8, patient just feels very pleasured, like taking menthol. So when tomorrow some company comes and tells I have a new drop, this is exactly what it does. Next one. This is something which is very, very important. This is my last slide for today, but I think this is something which is very useful for everybody when there are a lot of spelling mistakes. I only made it using something, but it's okay, giving you an understanding. So what happens is, there are two very important things in ocular pain. That's why we have to start this treatment very early. One is, in the cornea, you have all your inflammatory markers. Chronic pain which keeps developing through your trigeminal nerve, this is called as the peripheral sensitization. That means you are in the peripheral level. Problem with a lot of people who come to you being unhappy is it reaches your brain and your limbic system. So every pain in your eye, once it reaches your amygdala adds sprinkle fear, threat and anxiety. It adds that. So the pain which was there in the eye, when it reaches the brain constantly, amygdala has sprinkled fear into it. And after that, it comes to a pathway called limbic system, which is hippocampus and anterior. And what these two sprinkle is, it gives you a psychological emotion. That means it tells you you're never going to get better. Amygdala puts fear. Anterior cincinnate cortex, that is ACC we call it, adds a psychological emotion that I will never get better. But there is something called as posterior cincinnate cortex, which always infuses positivity. That it will tell you that it's that voice which keeps telling you. And hippocampus stores that in a library. So this is how a pain happens. So a chronic pain reaches the brain, it goes to amygdala, it adds that this pain is fear. I'm going to lose my eyes, I'm going to die, is fear. That's why this cartoon was about suffering. And after that it goes to the anterior cincinnate, which gives him a terrible sense of unhappiness, and hippocampus stores it in the library. So the library, that means every time he sees AC, he says, I'm going to get pain, because hippocampus is telling him, you're going to get pain. And when he gets completely depressed. So when you have a patient who has these kind of symptoms, that's the time you need to start looking at GABA analogs, because GABA analogs knocks this off completely, because you need anything high level of gabapentin, the GABA increases the sense of positivity. That's why when they give you a GABA analogs to treat, remember the neurologists are treating these three pathways. So remember, when you talk about any dryness or ocular pain, you have a peripheral sensitization and central sensitization. Minute the patient has an emotion to the pain or psychological emotion to the pain, it has already reached the amygdala and the limbic system. At this point of time, you have to just tell them, please start on a neurology. I know you need, but your neurologist will do, because he will take care of. See, this is where we have to be very clear and explaining to them that there is a peripheral and a central sensitization. You have to have a neurologist who is in sync with your understanding. And you will tell him that why you need him is because in a central sensitization, none of his drops work. Because he already gone to this stage. 99% of your patients who are this are already in this stage, right? You're already emotionally upset, dramatic.
But what neurologist would do different other than writing GABA?
Gabapentin will work. What does GABA do is it.
My question is, why would we only prescribe gabapentin?
See, GABA is again one side of. See, you know when to stop. Some patients may not want to stop, and he may commit suicide for some reason, for whatever reasons. Then why should we get into that trouble? See, I'm talking from a medico-legal aspect. So I end today's talk because this is the foundation, fundamental way how you manage your ocular surface issues. Remember, amygdala pain, the limbus system is how much I suffer. If hippocampus was not there, and the descending pathways are your serotonin and norepinephrine, and they block this pain. So what does your serotonin SSRI do? They block whatever is coming from these guys here. So if you use GABA, it works here. But if you use the SSRIs, the serotonin reuptake inhibitors, it will work on them. So this is how you manage pain from tomorrow.
Can you give an example of this serotonin reuptake inhibitor?
There are a lot of them, but you can talk to, see, if you want to write it yourself, you can talk to a neurologist and you can write it. It's no harm. But you need to know when to do it. So every time you see this kind of patients, take a call, is it a central or a peripheral? If it reaches central, You have to aggressively look at it. And all the patients who come to your patient's clinic more than 3 or 4 times have already reached central. The first line of central is GABA. And the second line is tricyclic antidepressants. It works on hippocampus. The third is your SSRIs, which works on these guys. It worked.
Up to what? Retina surgery. Retina surgery.
Just check their epithelial status in the morning and do it in the evening. And if you see there is a difference, that means there's some epithelial edema there. And they may be keeping their eyes open, or some amount of thing is there. Just check them in the morning and evening, epithelial edema and things. Yeah, and even epithelial maps also, if you can.
So at the end, I would like to thank Dr. Rohit and all the national faculties, Dr. Natasha and the 2 dear fellows who have come along with Bangalore, and Dr. Wavikar sir. So it was just a mind-blowing experience. It was very nice. And I think Urvaja also wants to say some words, especially for Rohit, as far as I know. So Urvaja, will you please come over here?
I would thank Dr. Rohit, Natasha, Dr. Aarti, and all of you that you have been the part of this day's program, and we definitely learn as we have always learned every day. And thank you so much, sir. Thank you for coming to Indore.
Basically, to complete the vote of thanks, I thank all the participants for staying till 4 o'clock. For Rohit, who got up at 3 o'clock in the morning, took a flight from Delhi, came here, awake whole night. Now also he looks sleepy, but he's going to travel back to Bangalore tomorrow, head back to the lab. Thanks all the delegates, thanks Sun Pharma. Without your full support to me and Team NN, this wouldn't have been possible. And I'm sure after this meeting, your 2 brand names will be very popular and you won't complain, sir, sale nahi mil raha, sale mil jayega. So thanks all of you. Thanks Brilliant Convention Center. Sachin is here. Every time Brilliant Convention Center is like a second home. Whatever we say, they cooperate. This hall was not supposed to be given for such a small attendance, but they're like, sir, IDOS, we are there for you all. And thank you for all our outstation guests who have come to attend this refractive meet. It's a day-long meet, but as I told, we don't want empty halls. We want focused people who want to come and learn. And this was the meet today where focused people have come and learned. So thank you once again. Thank Funny for helping us and the fellows. Thank you.
Thanks. Rohit sir, I attended one of your sessions at Bhopal a year and a half back. So that was one thing wherein you had just started giving such kind of lectures. This is one step, not one step, maybe 10 steps ahead. And I'm looking forward for your third session. Probably that would be really beyond thing. So you had started, you showed that video wherein tree hellos, how the cell starts regrowing itself. That was one time when I went back, Alcon ke products hatake, it was Soha liquid gel. So yes, it works. Irrespective of anything, it really works. But this has been beyond. Okay. Thank you so much.
Thank you, Rohit,
So I think the
just
next
the special orientation which you told. You should be aware what people want around you. So
I
I was
think,
correct, right?
Special orientation. I think all of you should teach your children also. My wife Naina keeps telling that when they come back from school, or forget kids, we also, we just remove our shoes and go. If you're spatially oriented, you will. This is not OCD. You can look at your orientation. You'll be straight. And if you're not spatially oriented, so she said, okay, come see what you have done. Oh, that means for a second you come back to senses that My orientation is not there. I think the greatest gift anybody can get is how spatially oriented in your clinic. You can ask this Vibha or Abha. I said, your hand is touching his something. And he said, and see, when you have to do like this. I said, please don't touch because, see, that is spatial orientation. You're teaching. And if you inculcate in your practice, for example, you are peripherally, you know what is happening. So one of the challenges today is we are not spatially oriented at all. And because of that, we miss out a lot of things. So everybody is busy, everybody has their own things. It is not something which is inborn, definitely no. Spatial orientation is like neuroplasticity. More you are oriented, more you start doing, it becomes neuroplastic in nature. And more you start observing it, it becomes part of it. So I think one thing is, if you can remember and you can read more about it, it's a very new topic in psychology. It has been the oldest topic, but they want to bring it to ophthalmology, and whatever I teach them, keep observing, and that helps you to decide which patient you don't want to do refractive surgery or multifocal. Because many times we miss a patient because we are not spatially oriented at that moment. And he's already giving you clues.
The time they enter,
They have the clues. First time is somebody will take out her tissue and start rubbing on the slit lamp. For me, that is the first spatial orientation, that this person, she doesn't trust you. Okay, everybody doesn't do it. One person will be there. I don't know, you must have seen. They will, minute that happens, I will say, this person I'm not going to do silk or smile. I will do contura, which is straightforward. Because this person is so fussy that they cannot expect. People ask me, because that is how it is. Because if I do on her, if she's so fussy about that cleaning, then how fussy she will be about day one vision. And if she is not happy, what she will do? She will start accommodating. When she accommodates, what happens? You get double vision, triple vision, and you're finished. That's the take-home point for this meeting.
It's a smartphone usage leading to more lack of spatial orientation in children.
Yeah.
Yes, so dopamine hits, no? There's a huge article on that.
And then they're not even observing what's happening around.
See, it's like this. The spatial orientation pathways, you have dorsal and ventral. Both of them are dopamine-dependent pathways. So your spatial orientation is good when its dopamine is high. And that is why it is very important. And myopia children have less of dopamine. So you don't have dopamine. And that's the paper which we are working on. Vibha has worked heavily on it. It's going to be a landmark paper. The less dopamine in the tears makes the myopia to grow more. You need dopamine more in the tears, and cornea secretes dopamine. More dopamine in the tears makes the atropine to work better. So this is something which we can discuss next time. Again, good question. You need a receptor. And what blocks the receptor? Chronic inflammation. That's why final solution for a lot of diseases is improve the receptors by reducing inflammation. Last 7 years, every known Nobel Prize in the last 7 years in physiology medicine has been in one or the other form of inflammation. Last 7 years, never been there. Even this time, the person who got his T regulator cells, which they've harnessed. So that the next 20 years, every Nobel Prize is going to be on one or the other immune regulation. Unfortunately, ophthalmologists, the big names in this world, who have just decide that there is nothing called inflammation. And that is why it's been taught to generation that everything is skill, everything is optics, but there is no biology, which I think has to be eliminated.
Yeah, it's been an eye-opener. Thank you so much.
I would be very happy if you all go and practice, and Indore referral centers like yours and you here bring the concept of peripherals and central sensitization into your practice. You practice on a neurological center, work with team. It's a great scope for working with neurologists and becoming an authority on central and peripheral sensitization. Only when you have the multi-speciality you can work, and start looking at it, read about it, and think about it. That's why I wanted to show you that last slide, because each one of you can take that as your specialty area. Because people who suffer actually suffer.
Thank you, Rohit, for keeping your promise. Last year you promised me you're going to be here this year. So thank you once again. And I want everybody here on the floor for the last group photograph we are having.